Welcome, everyone. Today we're diving straight into a rigorous PhD-level explainer of vascular liver disorders. We are setting the stage for a completely lossless anatomical and clinical breakdown of the pathologies that completely alter the hepatic hemodynamic landscape. If you've ever wanted to understand how a microscopic vascular blockage can dictate the entire trajectory of a patient's life, well, you are in exactly the right place. We're going to map out these conditions with absolute precision, visualizing the exact vessels and the clinical outcomes involved.
Here is our ultimate framework for today's clinical review. We'll start by mapping the anatomy of portal hypertension, then transition into the high-stakes dynamics, diagnostics, and interventions of Budd-Chiari syndrome. From there, we'll move proximally to EHPVO in pediatric populations, followed by NCPF in adults. Finally, we'll synthesize all of these vascular liver disorders into a single, high-yield comparative matrix. Let's get started.
Section 1. Anatomy of portal hypertension. To truly grasp these pathologies, we first have to map the precise vascular locations that dictate entirely divergent clinical outcomes.
Okay, let's dive into this. The entire module revolves around exactly where the obstruction occurs relative to the hepatic sinusoids. It's like a giant plumbing puzzle. Remember the basic physiological flow. The portal vein and hepatic artery feed the sinusoids. The sinusoids drain into the central and hepatic veins, and those finally empty into the inferior vena cava. Now, if you obstruct the first-order portal vein before it even enters the liver, you have an extrahepatic pathology, EHPVO. Move into the intrahepatic third-order portal vein, and you're dealing with pre-sinusoidal NCPF. Sinusoidal blockages? Well, that's your classic cirrhosis-related portal hypertension. Move downstream to the intrahepatic post-sinusoidal space, and you have veno-occlusive disease. Finally, if you obstruct the hepatic venous outflow entirely post-hepatic, you are looking at Budd-Chiari syndrome.
Moving right into Section 2, Budd-Chiari syndrome dynamics. We're starting with the absolute highest-stakes pathology of them all, emphasizing its unique and incredibly dangerous risk of progressing to cirrhosis. What's truly fascinating here is the textbook extent of this occlusion. Budd-Chiari isn't just a simple localized clot. It's defined as a hepatic venous outflow tract occlusion spanning anywhere from the efferent ductule of the acinus all the way up to the entry of the IVC into the right atrium. When you obstruct that post-hepatic outflow, you create massive sinusoidal pressure. This venous congestion backs up and leads directly to hypoxic damage of the hepatitis. Specifically, this hits zone 3 of the liver acinus, where the oxygen tension is already the lowest. And chronic congestion here, it leads straight to cirrhosis.
You literally cannot discuss Budd-Chiari without identifying the underlying hypercoagulable states. Interestingly, secondary acquired causes are actually much more common than primary forms. If we look at inherited etiologies, factor V Leiden mutation is the single most important one, followed by deficiencies in antithrombin 3, protein C, and protein S. On the acquired side, polycythemia rubra is the undisputed primary culprit, though the postpartum state, pregnancy, paroxysmal nocturnal hemoglobinuria, and other myeloproliferative neoplasms are also highly significant drivers.
And this brings us to the classic clinical vignette you are going to see over and over again. A 30 to 40-year-old postpartum female presenting with subacute refractory ascites and portosystemic collaterals. This is, for sure, the most common presentation of Budd-Chiari. However, there's also an acute form, which presents with a very distinct triad: abdominal pain, hepatomegaly, and ascites. Noticeably absent in most of these acute cases is jaundice, which actually occurs in less than 10% of patients.
So, the absolutely crucial point here is how we analyze the ascites. This is a beautiful piece of pathophysiology. Typical sinusoidal causes like cirrhosis yield ascites with a high serum ascites albumin gradient or SAG but low protein. Budd-Chiari, on the other hand, produces a high SAG and high protein ascites. Why is that? Well, because the hepatic venous transudation happens proximal to the occlusion, which actually preserves serum albumin in the fluid gradient. The liver's protein synthesis is initially totally intact, and that protein is forced out into the peritoneal cavity by the massive hydrostatic pressure.
All right, let's move to Section 3, Budd-Chiari diagnostics and interventions. We need to make sure the precise ordering of these diagnostic modalities is perfectly clear. The exact procedural pathway for diagnosis here is strictly non-negotiable. Hepatic venous Doppler is always your initial screening tool. But don't stop there. A contrast-enhanced CT or CECT is absolutely the definitive investigation of choice for confirming the extent of the thrombosis. An MRI? That's reserved specifically for instances where you need to assess for the presence of hepatic nodules or underlying hemorrhage.
Now, this illustrates one of the most fascinating anatomical quirks in hepatology. On that CCET, alongside portosystemic collaterals or an isolated IVC occlusion, you will classically see caudate lobe hypertrophy. Because the caudate lobe possesses its own separate, direct venous drainage right into the inferior vena cava, it's often spared from the main hepatic vein occlusion. So it undergoes compensatory hypertrophy. It literally swells up to take over the work of the failing, congested liver.
When it comes to management, treatment escalation must be rigorous. Step 1. Systemic anticoagulation is mandated for all patients, but a patient should never be left on anticoagulation alone if further intervention is anatomically possible. Step 2. Angioplasty, with or without stenting, is preferred to mechanically open up that outflow tract. If those measures are unfeasible or if they fail, Step 3 is a transjugular intrahepatic portosystemic shunt, or TIPS, which serves as our final aggressive bypass resort.
But here is the stark reality. Despite everything we just discussed, despite anticoagulation, stenting, and TIPS, the 3-year survival rate for Budd-Chiari syndrome is a dismal less than 10% without a liver transplant. It is a profoundly lethal progression.
Let's step proximally back to the first-order portal vein for Section 4, EHPVO in pediatric populations. We're shifting from a lethal, cirrhotic pathway to a disease with zero risk of cirrhosis. Extrahepatic portal vein occlusion, or EHPVO, is characterized by a core identifying triad, a 3 to 8-year-old child presenting with a massive upper GI bleed and massive splenomegaly. It's especially common in the Asian context and is predominantly caused by early childhood umbilical sepsis and occasionally a prothrombotic state. Now, here is the academic hook, a real clinical paradox. Despite the massive variceal bleeding and portal hypertension, this child will have completely normal liver function tests and a totally normal liver biopsy. The liver itself is perfectly fine. The blockage is prehepatic. Therefore, the risk of cirrhosis is absolute zero.
However, EHPVO does have severe longitudinal complications. Because the portal vein is the main source of blood flow and critical growth factors for the liver, its occlusion leads to overall growth retardation in the child. Additionally, as collateral vessels form to bypass the blockage, they wrap around and compress the biliary system, causing portal biliopathy. The massive splenomegaly leads to early satiety, malabsorption, and hypersplenism, which just consumes platelets and red blood cells, resulting in thrombocytopenia and anemia. Let's see how this anatomy actually dictates our clinical management. When you image an EHPVO patient with a CECT or color Doppler, you're going to see a cavernoma. This is a cavernous sponge-like network of multiple collateral veins trying desperately to bypass the blocked main portal vein. Because the liver function is preserved, our main goal here is just to stop the bleeding. Therefore, endoscopic variceal ligation, or EVL, is the definitive treatment of choice. Beta blockers, they are relegated strictly to secondary prophylaxis, not primary prevention. Let's shift slightly downstream now to the intrahepatic presinusoidal third-order portal vein in Section 5, NCPF, adult presinusoidal venopathy. Non-cirrhotic portal fibrosis, or NCPF, is effectively the adult counterpart to EHPVO. The classic demographic is a young Asian male, typically 20 to 40 years old. Like EHPVO, they present with massive upper GI bleeding and massive splenomegaly. The exact etiology remains unproven, though there are academic associations with E. coli infections, arsenic exposure, and hypervitaminosis A. And just like our pediatric patients, the risk of developing cirrhosis here is almost negligible.
Now, what's really interesting here is the pathology. NCPF goes by several synonymous terms in the literature: idiopathic portal hypertension and hepatoportal sclerosis. While Doppler ultrasound remains your first-line investigation, if you perform a biopsy, you will find the gold standard hallmark, obliterative portal venopathy. Under the microscope, the portal tracts are thickened, sclerotic, and completely devoid of patent open portal veins. Those tiny vessels have literally been obliterated.
To truly master this material, we have to step back and look at the whole picture. Welcome to Section 6, Vascular Liver Disorder Synthesis. Let's integrate all this data.
Before we hit the master matrix, we must briefly isolate one highly specific intrahepatic post-sinusoidal pathology, sinusoidal obstruction syndrome, also known as veno-occlusive disease. This is strictly tied to a very specific toxic window. Day 0 is the administration of high-dose alkylating agents like cyclophosphamide for myeloablative chemotherapy or bone marrow transplant conditioning. Between day 10 and day 30 post-transplant, that is the classic window for this acute, painful liver swelling and ascites to manifest. Keep that rigid timeline in mind.
And this brilliantly illustrates the absolute climax of our explainer, a masterclass rundown triangulating every single disease by its exact anatomical vessel, demographic, hallmark, and prognosis. Look at Budd-Chiari. It's a post-hepatic outflow block hitting 30 to 40-year-old postpartum females marked by refractory high SOG, high-protein ascites with a very high risk of cirrhosis. Contrast that with EHPVO, an extrahepatic first-order block hitting 3 to 8-year-old children marked by massive bleeding and cavernomas with zero risk of cirrhosis. Finally, NCPF, a pre-sinusoidal third-order block hitting 20 to 40-year-old Asian males marked by upper GI bleeds and obliterative venopathy with a negligible cirrhosis risk. 3 different anatomical blockages, 3 completely distinct clinical profiles.
So, what does this all mean? We wrap up with this profound thought. How does the exact anatomical location of a microscopic vascular blockage dictate entirely divergent trajectories of a patient's life? Mere millimeters of anatomical difference determine whether a patient faces a benign, manageable course like EHPVO or a fatal march towards cirrhosis with Budd-Chiari. By mastering the anatomical flow, you master the clinical outcomes. Thank you for joining me for this rigorous breakdown. Keep tracing those vessels and keep asking the right questions.